Yeah, you can hear me. Hi, I'm Cindy Hall, President of the Women's Congressional Policy Institute, and welcome to this afternoon's briefing on neonatal opioid withdrawal syndrome. The Women's Congressional Policy Institute, or WCPI, as many of you know, is a nonpartisan, nonprofit public policy organization. Our mission is to bring women policymakers together across party lines to work on issues of interest to women and their families. And we work closely with the members and staff of the Women's Caucus, several of whom you will see today. I would like to thank our briefing co-sponsors, Congresswomen Susan Brooks and Lois Frankel, who co-chair the Women's Caucus, and Congresswomen Mimi Walters and Brenda Lawrence, vice chairs of the Women's Caucus. This is the 13th briefing in a women's health series we have been sponsoring over the past several years, underwritten by the Robert Wood Johnson Foundation. And it's the second of several briefings this year we will be focusing on opioids. We thank the Foundation for its support and its work to improve the health and health care of all Americans through its support for research and programs working to help build a national culture of health. Our thanks to our esteemed panel of speakers who you will be introduced to shortly, Dr. Diana Bianchi, Dr. Sean Loudon, and Dr. Uma Reddy, our moderator. This briefing is being videotaped and should be available for viewing later this week, so please check our website. We'll also send an email out once it's ready to go. So please let your colleagues know our website address is womenspolicy.org. We also will be live tweeting during this briefing, and we encourage you to join in using the hashtag WCPIHealth. And then a final note, please don't forget to fill out the green evaluation forms in your packets. They give us ideas for future briefings and feedback to make these events more useful to you. So I'm very pleased next to introduce Congresswoman Catherine Clark, who's going to give some opening remarks. She's serving her third term representing the 5th District of Massachusetts and is a member of the Appropriations Committee. She's a longtime champion of women's health, as many of people in this room know, and is the sponsor of several bills to address opioid and substance abuse, including the Protecting Our Infants Act that was signed into law last year.
Thank you. Good afternoon. It is wonderful to be here with you. I am so pleased to be here with this panel, and I will keep my remarks short because I want the real experts to get a chance to talk to you. But I also want to thank Lois Frankel and Susan Brooks and Brenda Lawrence and Mimi Walters and Cindy for all your great work and for bringing us together. I want to talk to you a little bit today about neonatal abstinence syndrome, which is what we call the various medical complications with babies who are born dependent on opiates. And this became an issue that we became interested in my office when we learned of a little baby in my district in Malden who was brought to our attention and had suffered from withdrawal, had caused seizures that were so severe that his retina had detached from these seizures. And we began to talk to neonatologists, experts, advocates about what we could do. And we found that nationwide, we needed to have better standardization of best practices and really collect great data on how to treat NAS and support the moms. And I want to, as part of the Women's Congressional Policy Institute, and we are thankful to the men in our audience today, but seeing many of you as women, this is part of the opioid crisis that we have to be particularly aware of, I think, as women. Pregnancy for women who are suffering from substance abuse disorder is an inflection point where women want to change their lives. They want to be the mom they hope to be, and they deserve our care, and they deserve our understanding. And what we have learned about treating these infants, we cannot separate from how we treat these moms. And that it isn't just about good prenatal care, but it's about what we do afterwards to continue those supports for moms so that we have the best outcomes. And to give you a little bit of the sense of the scope of this issue, every 25 minutes, a baby is born with NAS in this country. In my local community hospital a year ago, very small suburban hospital, 5% of the births are NAS babies and those moms, which is a staggering number. And nationwide, almost 40% of infants in NICUs are NAS babies. There is a tremendous cost to us as well financially, $1.5 billion a year spent in healthcare addressing this. 80% of that is paid for with Medicaid dollars. And this too amounts to a sharp increase. It has effectively doubled since 2009. But the good news is we were visiting a hospital in the Boston area, the Boston Medical Center, was that just yesterday? Just yesterday. And they've made tremendous progress. And I know that this will be shared with many of our medical experts that we have talking to you today. By using something as simple as Eat, Sleep, Console, really giving moms a chance and encouraging moms not to leave their baby's side if they are able, a focus on that comfort, that bond with the mom, has reduced the average stay at Boston Medical Center from 23 days to 9, and is allowing for 80 to 90% of the moms to be with these babies and to really be part and to find empowerment from being part of helping them have healthier outcomes as we go forward. But standing behind those statistics are wraparound programs that involve social workers and counselors and working with the Department of Social Services in Massachusetts to make sure that we continue to have good outcomes for the mom and for these children, because we don't really know yet the long-term effects of NAS on these children as they grow. And we want to make sure that a great, healthy start is carried out throughout their lifetimes for both the mom and the infant that is impacted. But we've got a long ways to go, but we know that this is a major public health crisis, and that the sooner that we can wrap our heads around that this needs to be treated as any chronic disease is treated, the better outcomes that we are going to have. And that really starts with reducing the stigma and realizing that our words matter and how we talk to patients, how we talk to moms, and how we deal with the entire holistic framework that can support these families and these babies. I was very proud to see Congressman Evan Jenkins come in. Congressman Jenkins has been a leader on NAS and also helped co-sponsor the Protecting Our Infants Act, which was really, this continues to be, as this crisis doesn't care if you're in a red state or a blue state, doesn't care how much money you have or where you went to school. It is an area where we can continue as a Congress to work together and reach across the aisle and put these families and these babies first. And I'm proud of that work, but we lose 6 people a day in Massachusetts to this crisis and almost 100 people across the country. This should be to all of us completely unacceptable, and that we have to not only change our policies, have better federal data collection, but we need more money. We need money to access long-term treatment for these families. As one doctor said to me, short-term treatment, short-term recovery. And it is a complicated disorder, but we know we have made great strides, and we know where we need to head to make a difference for these families. So I thank you for being here. I thank our experts in the field for all the work you're doing. And I thank my colleagues who have been such incredible partners, and to all of you for your interest in your role in helping us address this epidemic in our country. So thank you for having me.
Thank you so much, Congresswoman Clark, for all of your leadership. We really appreciated your remarks, too. They're the perfect way to start this event. So thank you. Congressman Jenkins, I know you're going to introduce Dr. Loudon. Are you able to stay for a little while, or do you want to make some comments now? I'm happy to stay. This lunch. Okay. All right, good enough. Well, then I'm very pleased to introduce Dr. Uma Reddy, who will introduce Dr. Bianchi and moderate the discussion following the presentations. Dr. Reddy is the project scientist for the Eunice Kennedy Shriver NICHD Maternal Fetal Medicine Units, MFMU, Network Pregnancy and Perinatology Branch. She manages diverse research studies focused on clinical obstetrics, reproductive epidemiology, and prenatal diagnosis. In addition to her scientific responsibilities within MFMU, she also serves as a project scientist for large research studies focused on adverse pregnancy outcomes. After receiving her undergraduate medical degrees from Brown University, Dr. Reddy completed her residency in OBGYN at the Johns Hopkins Hospital. She then obtained her Master of Public Health in Biostatistics at the Johns Hopkins Bloomberg School of Public Health, was a Robert Wood Johnson Clinical Scholar, and completed her Maternal Fetal Medicine Fellowship at Thomas Jefferson University in Philadelphia. Dr. Reddy.
Well, it's an honor to be here. Thank you, Cindy, and to the Women's Congressional Policy Institute for inviting me to this important briefing on a very important topic. I'm just overwhelmed. The Protecting Our Infants Act is a tremendous act, extremely well written, and has been a big motivation for the work that we've been doing. As we heard so eloquently from Congresswoman Clark, the impact of the opioid epidemic has not spared pregnant women. As you heard, one infant is born with neonatal opioid withdrawal syndrome, or NAS, every 25 minutes in the U.S. So because we recognize there was a dearth of research on pregnant women and these neonates, NIH convened a workshop in 2016, which was co-sponsored by the Centers for Disease Control, the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics, the Society for Maternal Fetal Medicine, and the March of Dimes. In this workshop, we convened experts from diverse disciplines to address key scientific opportunities to advance our understanding of opioid use disorders in pregnant women and their neonates to improve outcomes for these affected women, their children, and their families. Today, I have the honor of introducing Dr. Bianchi. Dr. Diana Bianchi is the director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development, NICHD. She oversees a large range of research, including pediatric and maternal health, intellectual and developmental disabilities, and medical rehabilitation. A practicing medical geneticist with special expertise in reproductive genetics, Dr. Bianchi also maintains her own lab at NIH. The recipient of many awards in her field, Dr. Bianchi earned her medical degree from the Stanford University School of Medicine, her residency training in pediatrics at Boston Children's Hospital, and her postdoctoral fellowship in medical genetics and neonatal perinatal medicine at Harvard. It's a pleasure to introduce Dr. Bianchi.
We've lost our... It's there, but not up there. So let me see if I can... It's Shift F7 or? Nope. Would have gone to sleep. Well, in the meantime, I'm going to thank everyone for being here and thank the Women's Congressional Policy Institute for having us. Our goal today is really to put a separate voice on pregnant women and especially babies. So I'm a neonatologist as well as a geneticist. So although I don't practice clinical medicine anymore, I have taken care of babies who are unfortunately withdrawing from various drugs. Opioids were not such a concern when I was last in the NICU, but you will be hearing from Dr. Loudon about what it's like today and some of the innovative approaches in West Virginia. So I could pretend, I mean, I can go through the slides, but
I think you better just go.
okay, we'll just start. This is a good test of being calm under pressure. So the first slide, it was supposed to show you a picture of Building 1, which is the sort of the headquarters of NIH. And really it was meant as a reminder that the National Institute of Child Health and Human Development is one of 27 institutes at NIH. And as Dr. Reddy said, we're focused on reproductive health, women's health, the health of families, and the health of children. So this particular problem falls right into our areas of expertise and interest in research. And we partner very closely with the National Institute of Drug Abuse, and in fact, the director of NIDA is right next door, Dr. Volkov, and she's talking about adults. So the next picture would have been a nice picture of the brain and all the drugs and how they affect the nerves and the brain. And as you all know, I mean, the basic problem is that most people are starting with the use of opioids as a prescription medication, but eventually, because of the euphoria associated with the exposure to the opioids, it gets harder and harder to achieve that same level of euphoria with just the opioids alone. So people who do get addicted then go on to other medications, including heroin, fentanyl, and carfentanil, which is an elephant tranquilizer. Congresswoman Clark spoke about NAS, or neonatal abstinence syndrome. The more recent term, and what I'm going to be using for the rest of my talk, is NOWS, neonatal opioid withdrawal syndrome. The change was because the babies aren't really abstaining. They're not making a conscious decision to abstain. They are withdrawing from exposure in the womb. The neonatal abstinence syndrome was first identified in the 1970s, and it refers to this constellation of signs and symptoms that Congresswoman Clark mentioned. These babies are very irritable. We talk about jittery babies. I mean, they're literally, you touch them, or even if you don't touch them, they're like this. They're very jittery. They have tremors. They have feeding issues. They vomit. They have diarrhea. Sorry, this is lunchtime. They sweat. They have seizures, as you heard from Congresswoman Clark. They cannot be consoled easily. So that's the fundamental problem. The problem is growing. As you heard, opioid use has quadrupled over the last decade. 259 million prescriptions for opioids were written and filled in 2012. And every 3 minutes, a woman seeks emergency care for prescription opioid misuse. And as you know from the news, the deaths involving synthetic opioids are escalating dramatically, mostly from fentanyl. I think we have visual aid here. Sorry. And deaths from drugs overall have increased dramatically, with 64,000 deaths from drugs. In 2016, and it continues to go up. So, looking hopeful. All right, go back. We'll go back to the brain. So here's the NIH, building 1, and here's the brain, your brain on drugs. So we've listed a number of the drugs, and again, they all produce this euphoric sensation. And even if the drug has been prescribed, regular use can lead to addiction. So we talked about this. And we're particularly concerned about use during pregnancy and the effects on the newborns. So as you heard earlier, pregnant women take between 3 and 5 medications during their pregnancy. And excuse me, there's been an increased prevalence of opioid use during pregnancy, so much so that there has been a 5-fold increase in the incidence of NOWs. We don't have more recent statistics nationally, but in 2012, the number that is commonly quoted, thank you, is that nearly 22,000 infants were born with NOWs. Thank you. And as Congresswoman Clark said, the charges, I mean, this is not only a crisis, it is costing everyone money. $1.5 billion for treating these infants alone. Again, you're in the other room, they're talking about all the adult issues, which are mainly concerned with the deaths. We're concerned with the pregnant women and the babies. And as I'll get to in a moment, the babies don't die, so it's a very different problem. In 2015, one county in Wisconsin spent more than $1 million out of a $9 million budget on child welfare placements alone, largely related to parental opioid addiction. So we think a lot about how to prevent neonatal opioid withdrawal syndrome, and it starts with prenatal care. The problem is many women who are opioid users are not getting prenatal care, either because they don't have access to it or they don't want to get prenatal care because they do not want to disclose their substance abuse. Why not? Because they're fearful that if they do that, their baby will be taken away from them. The recommendations are to screen pregnant women with opioid use disorder if we know about them at intervals during pregnancy to maximize their treatment, to determine whether the drugs that they're getting to appropriately treat their condition are at the right level. The medication is the standard of care for the pregnant women, and they're basically treated with either methadone or buprenorphine. Methadone improves compliance with obstetric care, results in higher birth weights for the babies, and lower incidences of preterm birth and infant mortality, which both have significant consequences for families. With buprenorphine, there's a decreased risk of overdose and also improved neonatal outcomes. Interest has increased in medically supervised withdrawal, but at the present time, it is unclear whether this would be safe for both the pregnant women and the developing fetus. Well, here's a crying, anxious baby. And our point today is we really need to think differently about the babies. They are different from adults. As I said, they don't generally die. Why don't they die? Because most babies are born in a hospital setting. So as Dr. Loudon and I know, one of the things that we do, even if we have no history of narcotic or opioid use in the mother, if the baby doesn't breathe, we are ready to give naloxone as a stimulant. So we're there, we will help the baby, breathe for the baby with a bag or with a tube. But one of the things that's running through our minds when we see a baby who's born depressed and not breathing is, could this baby have been exposed to drugs in the womb? But then there's a different group of babies that look fine in the beginning, but a few days later, and this is particularly an issue with methadone, 3 to 5 days after birth, then they start to have signs of withdrawal. And those babies may already have been sent home, particularly if it's not known that the mother has been using opioids. So then you've got a screaming, irritable baby with a mother who's an opioid user, and it's a recipe for disaster. Dr. Loudon's going to tell you about the situation in West Virginia where he works, and there the problem, it is a problem everywhere, but we're not just seeing opioid exposure, it's opioid plus other issues, marijuana, cigarette smoke, other drugs. And it's very hard for us as physicians to really separate out all of those issues. And this is really something new for all of us, both in the short-term and the long-term setting, to have babies exposed to so many different things. So what do? We try to manage these babies in a calm environment. The question is where to treat. Some babies could go home with their mothers. Some babies are sent to an intensive care unit where they are separated from their mothers. Dr. Loudon will talk about his special approach with Lily's Place, which is, I would call, a special setting. And it's important to know which of these approaches works best and how many are generalizable across the country. We need to encourage breastfeeding. The babies definitely do better with breastfeeding. And up to 80% of these babies need pharmacologic interventions, generally morphine or methadone, and they may need both of them. And then clearly they need an evaluation by social services. Can the baby go home? Does the infant require placement in a foster home? Representative Clark said that one of the reasons why the babies are doing well in the Boston Medical Center setting is they have a tremendous input from social services, and this is a very, very key part of the equation. I'll just quickly go through the breastfeeding is very important. Babies that are breastfed need less drugs. They are definitely calmer. The problem is that mothers who are opioid users, most of them do stop breastfeeding. It is fairly demanding, and many of them do stop. So that is not necessarily an option. So I just want to give you a little bit. By the way, you're hearing what I'm going to tell you now is new information. So we're going public with this information about what the NIH is doing in response to the public health crisis. So you're hearing it first here at this policy initiative. Well, we need to build expertise, and NICHD, so I became director of NICHD on Election Day. So I've been in my position for about 10 months now, and knowing that this was a public health crisis, we started the conversation, what is NICHD, the National Institute of Child Health and Human Development, doing in this very important area? Well, we only funded 2 grants in this area. One is testing a drug treatment in pregnant women and their newborns to reduce the incidence or severity of NOWs, and then studies to determine more precise dosing of buprenorphine in pregnant women, and that was started fairly recently in July of 2015. Dr. Reddy, along with others, co-hosted a scientific workshop that was sponsored by our institute to identify the research gaps going forward for screening and management of opioid misuse and NOWs. And the recommendations were published in an issue of Obstetrics and Gynecology in July of this year. And we're happy to send copies to anybody who's interested in this. In May of 2016, NIDA, our colleagues next door, announced a new research effort to reduce the time it takes to improve or develop new medications to treat pain, addiction, and research overdoses. And we work very closely with our colleagues at NIDA, the National Institute of Drug Abuse. So in the workshop, the following research needs were identified. Basic science, identify neurodevelopmental consequences of in utero exposure to opioids. Obstetric, determine optimal screening, treatment, and care during pregnancy. Neonatal, develop a new screening tool for neurobehavioral assessment of a newborn's functioning. Identify additional and optimal treatment approaches. And long-term, that's an area where we haven't really even been able to contemplate what are the consequences long-term on the developing brain of these infants who've been exposed to these drugs, and what does it do to their cognitive function and their overall health. So, as of yesterday, we have a new funding opportunity that NICHD has put out called Opioid Use Disorder in Pregnancy, and the research topics are the following. We are requesting applications for clinical studies of maternal medically supervised opioid withdrawal examining maternal, fetal, and neonatal outcomes. We're also looking for applications that study the way that these drugs are metabolized, because we know that there are variations in people's DNA that affects how they metabolize these drugs. So what might be a low dose for one woman is actually a high dose for another woman if she doesn't metabolize the drug quite as fast. And so both of these lower two bullet items are related to how your body metabolizes these drugs during pregnancy and what's the effect on the fetal and neonatal outcomes. Another very exciting opportunity is something that we're calling ACT NOW, which is an acronym for Advancing Clinical Trials in Neonatal Opioid Withdrawal Syndrome. You're hearing about it first. This is the first time it's been publicly disclosed. We were very fortunate that our director of NIH, Dr. Francis Collins, made some money available from his discretionary fund, knowing that this is a public health crisis and we needed to be able to act now. Typically, when we are making money available for research, we have a 2-year lead process. And that wasn't good enough for us. We have a problem right now. What can we do right now? And so that's why we started ACT NOW. It's a partnership between our institute, the ECHO program, which is the Environmental Child Health Outcomes program, which is based in the director's office, and NIDA. And it is a 1-year pilot opportunity in which these are our goals. We're going to develop a survey to obtain information on the sites, local practices, demographics, and volume of patients affected with NOWs. We're going to develop and conduct an observational study to obtain prospective data to inform development of a future clinical trial. And the idea is we will pilot a common protocol to generate evidence to inform best practice. Now, one of the things that we took advantage of is on the left, we have regularly funded for 30 years a coalition of groups that are aligned in our neonatal research network centers. And the ones that are colored in blue are the ones that are currently funded in this 5-year interval. The network started in 1986, so it's very mature, very productive, well-oiled machinery. It's located, the NICUs are located in 15 mainly urban sites, but those sites are not necessarily where the epidemic is at its highest. So we thought about how can we bring in West Virginia, for example, and how can we make this a partnership? And it turns out the Idea States Pediatric Clinical Trials Network started relatively recently. And if you look at the map on the right, the states are quite different. And those happen to be the states. They're mainly rural states, and those happen to be the states where they have the higher prevalence of NOWs. So the two groups are working together, and the wonderful thing is in the Idea States network, the investigators there are a little bit newer to these type of trials. So there's a partnership in terms of mentoring between the Neonatal Research Network and the Idea States. And we're hoping to have a common protocol that can then be applied. You can see that, for example, Ohio is a state where there's a high incidence. It is a Neonatal Research Network site, so we're hoping that the common protocol can be applied there, for example. Lastly, I just want to mention the 21st Century Cures Act, and I thank the representatives in the room for voting on that. And we have a number of responsibilities associated with implementing the Cures Act, one of which is NICHD is leading the task force on research specific to pregnant and lactating women. So we are going to have 3 meetings. We held one in August, and then we have to come up with a report and recommendations to HHS Secretary Price by a year from now. And this is an opportunity for input on medications and other therapies used by pregnant and breastfeeding women with inclusion of long-term outcome in terms of newborns. And this is giving new attention to an understudied issue. And as part of the analysis for our first meeting, we were quite surprised to find out that there was a literature search performed, and there have only been, in history, 25 randomized clinical trials examining the use of opioids and tobacco in pregnant women. So there's clearly a large, if you look at that, how it's studied in a very limited way, and the size of the epidemic, there's a tremendous opportunity for more research. So my last slide, my take-home messages are, as everyone in the room knows, the opioid epidemic is a public health crisis, but NOWS specifically is a growing problem, and babies have different treatment needs than adults. And most of the research at present focuses on short-term treatment, but the long-term effects, we are going to have a generation of children who have been exposed to these multiple compounds. And we don't know what that's going to mean when they start to hit the school system, for example. Multidisciplinary partnerships, both within NIH and outside of NIH, are very much needed. And I just want to remind you that our role is to perform the research that generates the evidence upon which professional groups can make recommendations to the treating healthcare providers. So I think I'll end here so that Dr. Loudon can get his time, and maybe we'll answer questions at the end. Thank you very much.
Thank you so much, Dr. Bianchi, for an excellent introduction to this important issue and your exciting announcement today. Always nice to have news. Apologies to Congressman Jenkins. We're just going to give Congresswoman Lois Frankel, the co-chair of the caucus, 1 second. She wants to say hello before Congressman Jenkins introduces our next speaker.
Okay. Thank you, Congressman. I wanted to come by. First of all, thank you, Cindy. Thank you all, Women's Policy Institute, for what you do here. And I wanted, listen, there are a lot of crises facing this world today, right? We got North Korea, we've got hurricanes, earthquakes, NFL players kneeling down. I mean, but here's the thing. This opioid crisis is near the top of the list, if not for our country. And so I want to thank the panelists and the congressman for being here and dealing with this. That's where I wanted to really come by and say, I can't, those of us who've gone through childbirth and you have a normal child born, it's the most joyous moment of your life, right? Once the pain is over, really. It is the most joyous. And you wait for the cry to make sure your baby is breathing, right? But to have a cry of agony is heartbreaking. So thank you for what you're doing, and I'm glad to see, members, you can see members, we don't have time to sit and think sometimes, but it's so good to make sure that there's staff and interns and people who are interested in this, and so I thank you all and enjoy your lunch. Thanks. Thank you. Nice to see you. Thank you. Enjoy. Nice to see you.
Thank you so much, Congresswoman Frankel, who, as anyone that attends these briefings knows, she comes to pretty much every one. She's an incredible leader of the caucus, representing the 21st District of Florida, where she has been very concerned about this epidemic.
Yes,
so thank you so
time.
much. And I know you came from a committee hearing too.
Yes,
so
I'm going to run back. Okay.
Thank you. Congressman Evan Jenkins, thank you for being so patient, is serving his second term representing the 3rd District of West Virginia. He's a member of the Appropriations Committee and is a sponsor of several bills to prevent opioid abuse, including a bill to address neonatal abstinence syndrome, which became law last year as part of the Comprehensive Addiction and Recovery Act. And he will also be introducing our next speaker.
Well, thank you very much, Cindy. And I wiggled my way onto this agenda. Dr. Loudon is my hero. And when you know that your hero is going to be in town, you say, please, please, just let me get close. Dr. Bianchi, Dr. Reddy, thank you so much. Thank you for all you do. I think there's 3 things going on here. Number one, I just want to share from a policy standpoint the good work that is being done under the dome here and through capitals throughout the country to address, I'm going to change NAS to NOWs. You learn something every day. The second thing is the awesome work and the investment from a research standpoint. Figuring out how we address what we all know is an epidemic. Who cannot want every child to have a healthy start in life? And the third is the wonderful work that Dr. Loudon and so many of his professional colleagues. One quick story. 5 years ago, as a state senator, I get a phone call from 2 NICU nurses at Cabell Huntington Hospital and saying, Senator, you need to come down and see what we are seeing. This is 5 years ago. Over half the beds at the NICU were taken up by babies suffering through NOWs. We know now the incredible life-saving support that a NICU offers may not be the perfect care environment for these newborns that are highly sensitive to touch, to sound, to light. And they said, we've got to do something different. And over a 2-year road of passion, we started Lily's Place. These 2 NICU nurses, myself, Dr. Loudon, and an awesome community leader and others. And today, we just celebrated our 3rd anniversary with over 190 newborns taken care of. And the kinds of research that they are doing, talking about what is the medication management best practices, what is the care environment best practices to give these babies the healthy start in life. And I took that experience, as Cindy just referenced, and passed legislation with a bipartisan, strong, passionate group of legislators signed by President Obama that says we are going to do some cutting-edge research. And within the next 6 to 8 weeks, we're going to see a GAO report out on just this topic. One of the things that we found was the challenges of breaking through the red tape and trying to fit a square peg in a round hole. We know that the healthcare environment is heavily regulated from a billing and coding and a reimbursement and a licensure and a regulatory. But trying to do something different to address an immediate need is a challenge. So that's what so many policymakers that I have the honor of working with here in Washington are doing, trying to get the policy right, trying to get the funding right, so these awesome researchers can support cutting-edge research around this country and awesome providers, healthcare professionals like Dr. Loudon. So to the introduction of Dr. Loudon. It has been a labor of love for me to have 5 years' experience of Dr. Loudon being the medical director of Lily's Place, literally a one-of-a-kind facility that he will talk about. He is a graduate of Marshall Medical School and the residency. He is fellowship trained. He's got, just like so many, credentials as long as your arm. But mostly I know him to be a passionate, caring physician that gets up each and every day with one mission in life, and that is, whether it be at the NICU at Cabell Huntington Hospital or the NTU, a facility at Cabell Huntington just taking care of Now's baby, or at Lily's Place being the medical director. And I have to put a pitch in. When we talk about this high incidence, we are ground zero in my hometown of Now's. But we also are ground zero for some really innovative things happening that I hope that our research partners will look at and say, man, that's where we need to invest, because they're doing some pretty neat work. Dr. Loudon is terrific. Dr. Loudon, thank you for coming to Capitol Hill. Thank you for all you do for the babies, and I appreciate your friendship. Folks, Dr. Sean Loudon. I ran off.
Thank you, and thank everybody for allowing me to come and share our experience in West Virginia. and lend a voice to the babies who we want to help, who we are helping every day, and who we are going to help in the future. So I wanted to sort of talk about how we are caring for babies, but I also want to at least touch on it at the end about how we are sort of wrapping around our whole entire concept of how the families really do impact what we're talking about with the care of the babies as well. So really the way we should sort of think about NAS and NOWS is really that it is the tip of a much, much larger iceberg. The end result of this opiate use crisis that we face really ends up with being a baby who is born exposed. But there are so many other things that we have to consider that really deals with the whole crisis. So NAS really does represent an entire population, and I'll show you some statistics that our own local data really does go hand in hand with the numbers that we see as far as babies with NAS. We also have an at-risk population who we have identified. I'm going to talk about very specific brain changes that occur with babies who are exposed to opiates. We know these babies are at risk for many things later in life. We've identified them, so now it's our job to follow those babies over time. And then frankly, we do have to consider how moms are the fundamental sort of to the family stability unit. It takes a village, but we have to have the chief involved, and we need her to be as healthy as she possibly can, so that way we can impact that whole entire family unit for years to come. We've seen the brain, and now I want to sort of go even more microscopic. The early period of fetal development is really where a lot of nerves and connections and all those things are made. And sometimes this is before women even know they're pregnant. So it really goes back to asking those questions. From the time the sperm could have met the egg, you know, what has this unit been exposed to? And all of that does matter even months later. So I think it's a matter of physicians, we do have to recognize the impact of even early substance use on developing fetal brains. And again, that brain development doesn't just stop whenever birth occurs. We're continually making connections until we're about 2 years of age, and then we sort of start pruning things so we're smart as we're ever going to be when we're 2, and then we just get dumber after that. But it is a very important process that occurs, and how all those early child life experiences go into the development of the brain is important as well too. So new nerves are made, as well as receptor changes occur very specifically throughout portions of the brain, the nervous system, and even in the GI tract. So all of these are areas at which babies experience withdrawal, and it is due to these very basic changes that occur in their brain. The problem is we don't know exactly how many of these changes occur in each and every baby, and it's different for each and every baby. So that's part of the challenges that we face whenever we are taking care of babies, is we have no idea how many of these changes occurred in that individual patient. And so that's why it is a very individualized approach to the treatment of each and every baby. The other thing is, frankly, the message that I deliver to parents is, frankly, your baby's brain has been rewired. What I'm trying to do and I'm trying to accomplish over the course of treatment is to change some of that back. But I am not going to change everything back to perfect or normal. I hate using those words, but by the time your baby goes home with you, and frankly, I don't know if it ever will be perfect or normal in the future. That's part of what we have to do and we have to address. This is my life. So in 2000, from 14 on, at our hospital, we have approximately 20% of every pregnancy exposed to drugs. So what that relates to is obviously about 10%, somewhere between 10 and 14% of all of our babies experience withdrawal. You may sort of say, okay, 2012, things just got really bad in Huntington. Unfortunately, I wish that were the answer, but frankly, that's when we started looking. So if you are in a place who doesn't look, who doesn't screen, who doesn't really sort of investigate what you're doing, frankly, your curve is going to do the exact same thing. When you start looking for babies and moms and pregnancies that are exposed to drugs, you're going to find them. And that's what we saw in 2012. Our numbers, our raw numbers, yes, they're very difficult. We treat upwards of 300 babies each year for withdrawal. Part of what makes our sort of neck of the world a little unique is that over half of the pregnancies that are exposed to drugs, those babies are exposed to more than one drug. And that's not even including nicotine, because we don't actually even include that in our cord because, frankly, the moms tell us that they smoke cigarettes. So we're finding that these babies are not just exposed to opiates, but many other things, and that really does impact the care of these babies afterward. Now, how is NAS sort of a representative of the population? It's because, frankly, when we look at the numbers of babies who are exposed in our hospital, we're somewhere between 14 and 21%. When you look at local EMS data, when you look at the health department data and the harm reduction clinics that we have, they also report about a 14% rate in our population. You know, our tri-state area has about 300,000 individuals, and our city has 50,000 individuals. And we're talking about the fact that we have about 10,000 people in our town that have an opiate use disorder. And so those are where our numbers sort of lie. Now, what Congressman Jenkins said was absolutely true. There were times in 2011, 2012, where you walked into our NICU and half the beds were taken up by term babies who were going through withdrawal. Now, what that meant was, frankly, when we got a phone call from one of our outlying facilities that they had a 25-week infant who was born who needs our help, we had to say no. We had to say we're full. We can't take you. So then that family had to go 3 more hours away. So we were turning away many, many babies who needed the life-saving capabilities of our NICU. So we knew we had to do something different. We were fortunate enough to be able to open up the neonatal therapeutic unit within the hospital, as well as an outside standalone nonprofit facility called Lily's Place. These units are very specifically there to treat neonatal withdrawal. That's it. That's our sole purpose. Now, in doing so, we've saved and opened up the critical beds necessary. So in 2011, 100% of NAS babies were treated within the NICU, and now, frankly, only 20% of babies with NAS or NOWs are treated within the NICU. And frankly, that number hasn't changed because those are premature babies or sick babies who have withdrawal. So we have reduced it to as bare minimum as what we possibly can for the number of babies who we treat within our NICU. You can see there that we opened up Lily's Place in 2013 or 14, and we have been able to steadily increase the number of babies who can utilize that facility as well. Now, these are very specific, specialized care. The environment is very, very specialized, reducing noise, reducing light, handling these babies and all that. Not only is it good care, but frankly, we're saving millions of dollars. So you can see that over the course of the past few years that we've had these specialized units open, we've saved, now these are charges, because I don't exactly am privy to the actual cost data. That's a little bit above my pay grade. But from a charge standpoint, we've saved the state of West Virginia $11 million in charges because of the rerouting of babies out of the NICU. We've saved Ohio Medicaid about $3 million and Kentucky Medicaid about $2 million. Now you may ask what the difference is. Well, frankly, I can tell you the difference is red tape. So the only babies that I can take into Lily's Place are West Virginia residents, because we officially, from a federal standpoint, are not recognized as a unique healthcare facility. So we partner with all of the West Virginia sort of Medicaid, private insurance payers, et cetera, et cetera. But because that's not crossing state lines, I can only offer the services of Lily's Place to West Virginia babies. If we were able to sort of move that needle and CMS recognizes a unique sort of healthcare center, then I could offer this service to babies in West Virginia or in Kentucky and Ohio as well. So that's sort of part of what Congressman Jenkins was sort of talking about, is that we do need to sort of be thinking outside the box. We do need to at least recognize that there are some other options, and frankly, it's better care for the babies, and I could potentially save millions of dollars in their care as well too. Now, why is it important that we do at least consider what the moms are going through as well too? We do need treatment for moms, and this is really why. Long-term treatment is really the key, because it takes an average of about 12 weeks for a pregnant woman or postpartum woman, once she enters treatment, to become sort of compliant in her care. So this is just a graph that shows when they have a sort of negative urine drug screen for anything other than that which is prescribed. It takes about 12 weeks for about 80% of those women, and then 25 weeks for about 90% of those women to achieve success. So we really have to be thinking about this from a long-term standpoint. Now, also why mom's impact with things is, frankly, her health impacts the baby afterward as well too. These graphs just show mothers who were diagnosed with major depressive disorder and with panic disorder, when their babies are going through treatment, they actually do require more treatment and with more drugs whenever they do carry those diagnoses. And this next one is most striking, is postpartum depression. You can see the vast difference between babies whose moms are diagnosed with postpartum depression and the kinds of treatment and difficulty that those babies do experience. The other thing is, just once they're in treatment, frankly, it saves healthcare dollars afterward as well too. In the first year of life, when a mom and baby dyad is in a medication-assisted treatment program, it's about a third of the cost to our hospital in that first year postpartum, both from a mom and baby visiting ER's standpoint. So if we can have them initiated and engaged in their own treatment, then we're much sort of better off from a healthcare standpoint as well. With that, I will stop talking so we can open up the floor to questions. I really appreciate, again, the invitation and the opportunity to share the baby stories. Thank you.
Thank you again for excellent talks, Dr. Loudon and Dr. Bianchi. So I'd like to open up the session for questions. Please identify yourself and your affiliation.
Good afternoon. My name is Carmela Watkins, and I'm with STEAM Onward. Dr. Bianchi, you recommended that mothers or babies should be breastfed, and I'm thinking if the babies are breastfed, the mothers are probably on some opioid. How is that helping the baby?
So that's a great question. So probably we should clarify that, you know, these need to be mothers under some sort of treatment and hopefully have been treated. But then again, the amount of drug in the breast milk is considerably less than is in, you know, crossing the placenta during pregnancy. Do you exclude pregnant women breastfeeding if they are known to be on anything?
So the recommendations are that these women are maintained in a supervised treatment program, and they are compliant in those programs. So therefore, they don't have any other substance other than either methadone or buprenorphine-based products, which are very relatively decreased in the breast milk. Now, having said that, marijuana, benzodiazepines, street opiates, heroin, all those things, if moms are positive for that, then they are not recommended to breastfeed if they have illicit or other substances that would alter breastfeeding.
And just
I would say, yeah, oh, go ahead.
Yeah, excellent question. Right, so those circumstances that Dr. Loudon explained are there, then women are told HIV is another condition, then they're told not to breastfeed. But women who are under medical assisted treatment do better breastfeeding, and their babies have less severe NAS, so it's a beneficial effect for both mom and baby.
Yeah, so it's a risk, I was gonna say risk-benefit calculation, so that even if they're getting exposed through the breast milk under treatment, the positive aspects of breastfeeding outweigh the fact that they're still getting some exposure to the drugs, but we'll be tapering the babies down in consequence with the mother's treatment.
And then I have a question. Could you go back to your graphs, Dr. Loudon? It was early on, and it was a progression. It was a discussion of what is being developed in the baby at the time.
The brain
So
development.
it was early on, the brain development, and yes, that one. So I'm looking at the bottom part of the graph, and it just seems like it should be equal increments, and so you have. Do you see what I'm saying? It should be, you got weeks, and then you have years.
So this is actually prenatal. So these are the developing sort of fetus here. And then we see as, after birth and as the ages go up, then that's where sort of some of these other changes that we do see in normal brain development occur.
Okay, yes, but I'm just saying the increments so you're not comparing apples to oranges. So
I think it's actually just a little bit better to sort of see the graphically what happens. I see what you're saying as far as, yes.
Okay.
It's not
visions are
linear,
there,
yeah.
but it's
Yeah.
more of a visual sort of aid
Right.
than specific time.
There's
Thank
a lot of
you.
brain development going on. I mean, the cells are dividing, the cells are migrating through the brain. There's a tremendous amount of activity going on that presumably is affected by the drug exposure.
yes, it's just that, mathematically it's not.
Thank you. Other questions? Yes.
First of all, good afternoon. My name is Kenneth Henry. And your slide on brain development, I'm wondering, to the extent that you have done research and collected data on your NALS babies, what the link or the similarities might be between these babies and babies from 20 years ago or so who were crack babies, or if there is any analogy between the two.
Yeah, so I mean, so I was in practice during the crack cocaine epidemic, and some of the superficial symptoms I would say would be very similar, and we may have had some differences in the drugs that we were using to treat the babies at the time. I don't think, honestly, we know yet how they're going to compare. Because this is still a relatively new epidemic. And I think the other thing that's different is the multiple exposures. So that's why we're kind of, in our thinking, in terms of the research plan for NICHD, we need to identify a short-term plan, but a long-term plan to be able to answer your question.
Some of what I talk with moms and families about from a long-term perspective are we do know that these babies are at risk for attention and impulsivity control issues as they reach school age. One of the other, and that's with opiates. Let me just clarify
Gotcha.
that is with opiates, as well as a new study out of Australia sort of followed these babies that babies with NAS, they used NAS as the term, compared to socioeconomically matched cohorts as well as babies who were sort of better, they do have a statistically significantly lower score on those standardized testings that they do at like 5th, 7th, 9th, 11th grade than babies who did not have NAS as well. So there may be some cognitive differences as well, and I do talk about that with parents moving forward. Again, this population is at risk for that, whether that individual baby develops that, then again, I think it's a matter of pediatrics sort of following those babies over time and identifying anything early. Now, that's with opiates. Marijuana, benzodiazepines, cocaine, all those things, and you add all those together, and that's what's really sort of fascinating is what those combinations are going to lead to, again, 20 years from now in comparing those babies.
And this is just a very basic question to you, Dr. Loudon. At what age do these babies have less of a need to be cuddled, and when do they outgrow that, or is that something that follows them for some period of time?
So again, what I do explain to parents is, the AAP, the American Academy of Pediatrics, recognizes that there's actually a subacute phase of withdrawal that lasts at least 6 months of time after they're born. So we talk about that, and I do talk about that with parents that, frankly, I could walk into your living room and, have a cup of coffee with you, and I may score your baby a 16 on the Finnegan scale, but I stay around and, chat for a little longer, and maybe a 3. They're going to have bad moments, and it goes back to those very specific changes. I'm reversing some of those, and we're reversing some of those by treating these babies, but I'm not making that go completely back to normal. So that's why these babies can be set up to have these things for months, if not years, down the road.
Thank you.
You're welcome.
Thanks.
Good afternoon. So I'm Dr. Joya Career-Perry. I'm a OBGYN by training, but I'm the founder and president of the National Birth Equity Collaborative. So kind of building on the last couple of questions and the correlation between, as we called it, crack babies versus fetal abstinence syndrome. When we now as physicians try to test, and OBGYNs, I do trainings in hospitals around racial equity and maternal and child health. We don't see white women as having addiction, and so part of the reason we miss many of these babies in the NICU is because we don't assume that taking Valium will cause a problem. And so how are you, because universal screening is almost impossible to do, and so I've talked to some hospitals in Michigan and other places, how do we get people to get past their biases and see that also white women do drugs and that their babies are having impacts from that, and then reframing, because I saw that you had, when you say that there are multiple drugs in the women, they're also doing cocaine, right? So white women are also doing cocaine, and so how do we not racialize this disease and also ensure that everybody gets equal treatment? I know that's a lot.
Do you want me to? Oh. From the OBGYN perspective, it's a very good point. And so the workshop was actually inspired by a couple of cases of NOWs in a predominantly white hospital. I heard about these cases where the neonatologist had no idea these were, high socioeconomic families, Caucasian, and both babies had NOWs, and it was shocked, and we heard about it. So, the importance of this topic came to us. And so, ACOG, the American College of OBGYN, is now recommending universal screening of all women because, like you said, screening, you don't want to screen specific women because you're going to miss, the majority of cases. And it crosses across all socioeconomic, racial backgrounds. And it turns out more white women are now more white women are going to drug treatment facilities than black women, more women than men. I mean, it's totally shifted the demographics of who's going for drug treatment. So I agree with you completely. Universal screening is what ACOG is recommending, and we as OBGYNs need to do that. And then the problem is we can do universal screening, but a lot of women will not, are worried about the consequences of admitting to drug use and their children being taken away. So, I think the efforts we hear about, and Sean, Dr. Loudon can talk about his state.
I mean, when you look at the demographics of West Virginia,
Right.
we are not exactly racially diverse.
Right.
I mean, it's just a fact. So when you look, frankly, at our hospital and the percentages of babies, who are born at our hospital, we predominantly have Caucasian, a community. So we have a large predominance of women, Caucasian, who do have substance use disorder. The key is, again, judgment. We have to get rid of that. We have to get rid of the stigma. We have to just view this as the disease in which it is, and people need help. And it doesn't matter, how old you are, how much money you have, what kind of purse you have, what kind of shoes you have. It doesn't matter. It's just, we have to identify an at-risk population, and I don't mean just the baby, I mean the mom.
Right.
Because we see that if we can take care of her too, no matter who you are, it actually will help the baby. It helps both. Moms and babies help each other.
Thank you.
And you've been patiently raising your hand. I'm sorry, just to restate the question, you were asking about the interventions they're using in their program for the babies.
One of the biggest and first things is actually the impact on the environment. Both units, both the neonatal therapeutic unit and at Lily's place, we really do stress that non-pharmacologic intervention first. So we do have, very low light. We don't use, fluorescent lighting. We use natural lighting from the windows or, under cabinet lighting. We have a very, specific amount of noise that we'll tolerate, within the unit. We also teach each volunteer, each nurse, very specifically therapeutic handling techniques for these babies because they do like to be held and rocked a little bit differently and uniquely from babies, who, I hate to use normal, non-exposed, typical babies as well. So it's those sort of subtle differences from an environmental standpoint. If they do require treatment, then we do utilize basically the philosophy of we will replace the opiate, but then we will also use whatever other potential exposures they have from an adjunct therapy standpoint to try to, again, target weaning the opiates so that way we can try to reverse some of those changes over the course of time. We do utilize a vast array of medications for the babies as well too. So unfortunately, that is our biggest confinement is physical space. We don't actually have the capability to room in right now. Obviously, that is our goal, and frankly, our hospital administration sees the benefit of that. It's just they're trying to get hospital space is not exactly the easiest thing to do, but I will give my administration credit for actually, this is actually on their top of their to-do list.
Great, over here.
Good afternoon, thank you. My name is Mark Land Adizumi. I'm a licensed registered nurse in California, also a psychiatric mental health nurse, working in addiction medicine with Kaiser. One of my questions is, we get pregnant women come in all the time, and their first thing is, I want off. And we're like, whoa, no. You got to get on something else because the fear of aborting the baby. Has there been any more research done on tapering during pregnancy versus going straight to methadone or buprenorphine?
That's an excellent question and the question of the day. So there have been observational studies. So the concern always was that medicated assisted treatment is better because of mother, prevents overdoses, better care, better prenatal care, better outcomes. But there are a subset of women who do not want to be on medical assisted treatment. And observational studies have shown that the concern about increased risk of miscarriages, of stillbirths, of the baby being stressed out in utero when the woman stops taking or is tapered off her opioids. Actually, in observational data, it's not there. There isn't an increased risk. So then the concern is, what about these observational studies? There is less NAS in these observational studies. There was a study in Tennessee of 300 women who were, it's detoxification or medically supervised withdrawal, and they showed less NAS. But the key was there was a couple of things. The women who had intensive behavioral therapy, psychiatric follow-up were the ones who did much better. They had less NAS, and there were less relapses in those women. The problem with all of these studies are they don't have what happens afterwards, after pregnancy. So these women could overdose, they could, relapse, and we don't have that information. So it's a very good question. And so Dr. Bianchi talked about the new notice for research projects, and that's like the #1 listed one, which is studies on medically supervised withdrawal and outcomes from that.
And then just a follow-up question, if I may. Addiction medicine is a very taboo subject, even more so for someone who is pregnant. They will come into our office. We'll start them on Subutex. For some reason, our physicians rather use Subutex and methadone. But they're not part of our treatment program. They're not in our therapy sessions, in our group sessions. and they seem to get lost in the shuffle between OB and addiction medicine, and they're like, okay, I got my drugs, I don't need anything else. How do you overcome that?
And we heard a lot about that because the collaboration, the coordination of care of these women is very difficult. And there's also issues with being able to, share information between the addiction medicine specialists and the obstetricians. The difficulties of actually sharing the information. So that is a big hurdle. And then being able to provide multidisciplinary services. There are a lot of drug treatment programs that don't accept pregnant women, or they're not open to pregnant women. So that's a very important concern you brought up.
But I would think that, part of our goal today is to shine a light on this topic. And as more and more people talk about it and separate the specific issues for pregnant women and the newborns and ultimately the children, that my hope would be that it would become socially acceptable and that hospitals and treatment programs would specifically recognize the needs of pregnant women and include them in addiction medicine treatment programs. I can't see you. There you are.
Yeah, the ideal would be to have addiction medicine, psychiatric, prenatal services all in the same place. So thank you. Yes.
Hi there, my name's Nina Russell. Thank you so much for talking about this today. My question is, on the note of coordination of care, you've talked about how this population of children will be coming into our society, entering various of our institutions, like our education system. How can the social services network be preparing to adequately meet the needs and coordinate the needs of this population?
So that's really more of a care issue, so kind of research care. So we'll let you answer.
So awareness, frankly, and again, it is destigmatizing even that these babies have been exposed, to substances, because, one of the things that we at least potentially sort of see for the future is that, what maybe we have just thrown out there as ADHD or something like that, maybe it's not. Maybe it is a manifestation of substance exposure at 5, 7, 8 years of age. So it really is a matter of being able to identify those babies and follow those babies from a long-term perspective. I think also goes to teaching. So teaching the teachers, teaching the social workers, teaching, the wraparound services that these babies will need. So I think that's where we spend a lot of time in our area really having conferences with all of our social workers, birth to 3, preschool teachers, Head Start. Like, we really spend a lot of time with them so they understand sort of the basics, basic science aspects of what these babies are experiencing and how that will manifest, later in life as well too. So I think it's a matter of coordination and just education as well.
But it's also a matter of funding. So, these long-term studies cost a lot of money, and we'd like to be able to do, for example, magnetic resonance imaging studies to look at the brains, in living people, obviously, of babies who've been exposed to, a variety of compounds and see how their brains differ and function differently from babies who were not exposed. So again, as part of our agenda is educating you about the special issues for the babies so that we can all work together and have it recognized as a different challenge.
Thank you.
Any other questions? Yes?
Hi, my name is Camila. I have a question about the preventative measures from being obstetricians. What are the numbers in terms of usage of birth control for these patients, especially if they're reoccurring users, to decrease the number of nows and also increase the number of birth control, the usage of birth control? And are these patients less susceptible to use this because of access, or how is the access given to them? And are you all working with the addiction specialists that they might be speaking to as well?
That's an excellent question. So the use of contraception is very important. So unfortunately, there is long-acting reversible contraception is recommended, and there are specialized. I know of specialized programs to make sure women understand all the options available to them. So these LARCs, these long-acting reversible contraception, are ideal. So they're that's what's recommended, but unfortunately, these women tend to either not get it because of access or because, they don't make their appointments. So it's important. The successful places are the ones that are able to get women in and provide, counseling about this. Because, in the U.S. in general, 50% of pregnancies are unplanned, but unfortunately for this population of women, it's even higher. It's 80%. So that's an area we really need to target.
One of the unique programs that we have in our area, and it is where we have the needle exchange program actually at our health department. We actually do have various people attend those needle exchange programs, including women or obstetrical care who could potentially place long-acting reversible contraception at the needle exchange program as well too. We also have social workers from Lily's Place, so we're trying to engage that a population in their sort of comfort area as well too. So those are, and it's actually happening in Charleston, West Virginia as well too, at their health department.
Clinics as well for.
So we haven't been able to sort of get our foot in the door there, but we're trying different places to engage them in sort of their own environment and their own comfort level.
Thank you.
Yeah, and actually immediately postpartum would be the most convenient time, and so there are a lot of hospitals, offering that to all women because, instead of making a woman come back at 6 to 8 weeks, immediately postpartum is the best time.
Thank you.
Thank you. Any other questions? Okay, I'm going to turn it over to you, Cindy.
I want to thank each of our speakers and also Dr. Reddy for moderating. This was really interesting.
Great questions.
Yeah, great questions from the audience. We always wish the discussion could go on for another hour, but unfortunately not. And our appreciation again also to the Robert Wood Johnson Foundation for underwriting this briefing series. I really think has been incredibly educational. I know there are regular attendees among this group. And thanks also, of course, to our congressional co-sponsors and their staff, several of whom are here. And also, of course, Congresswoman Lois Frankel, who came representing the caucus. And finally, my thanks to Cheryl Williams, Sarah Placencia, Shannon Wilson, and Emma Rogers for their work to make this briefing possible. Thanks so much. It's a little overwhelming.